Good morning, everybody. My name is Dr. Enrica Marchi. I'm one of the assistant professor of medicine in the Center for Lymphoid Malignancies at Columbia University Medical Center in New York City. And our group has a long history and expertise in developing new treatment platforms for peripheral T-cell lymphomas. And I will be discussing some of our newest data during this interview. Here I'm showing you our group effort to try to explore the value of integrating PD1 blockade on epigenetic backbones for the treatment of peripheral T-cell lymphoma. The rationale of doing such studies is based on the fact that we demonstrated that different combination of epigenetic modifiers, including romidepsin and azacitidine or decitabine, romidepsin and pralatrexate, and pralatrexate and decitabine, produce potent synergy in preclinical model of PTCL. And on top of this, more recently, we'll be publishing data showing activity also in early phase clinical trial. Mechanistically, what we have demonstrated is that the combination of epigenetics drugs, including romidepsin and decitabine or romidepsin and azacitidine, uniquely affect a very high number of genes when we compare to the single agents. And when we have tried to identify which are the genes that are mostly and uniquely affected by the combination of romidepsin and decitabine or romidepsin and azacitidine, we identify these genes as cancer testis antigen, interferon, and endogenous retrovirus. In addition, also preliminary preclinical data have suggested that pralatrexate as well acts as an immunomodulatory agent affecting genes involved in hypomethylating, viral response, and apoptosis. Based on this preclinical and early clinical data, our group has decided to develop and assess the value of adding an immunocheckpoint inhibitors on our more active epigenetic backbone. So we have launched two multi-center, multi-arm international trial exploring the value of such strategy. In the first study, we are studying the role of pembrolizumab added on pralatrexate and decitabine, or decitabine alone. And this is a phase 1 trial that we enroll patients with relapsed and refractory peripheral T-cell lymphomas. And in the phase 1 of the study, only patients with relapsed and refractory disease will be accrued, while in the expansion phase of these studies, also patients with de novo disease will be enrolled. And at this moment, and the data that I'm going to show you include the 13 patients that were enrolled in these studies. In the second study, this is again a phase 1/2A international multi-center, multi-arm trial that is exploring the value of adding durvalumab on an epigenetic backbones. This is a 4-arm study that explores the combination of oral 5-azacitidine and romidepsin plus durvalumab, pralatrexate romidepsin plus durvalumab, romidepsin plus durvalumab, and oral 5-azacitidine and durvalumab in patients with relapsed and refractory and de novo peripheral T-cell lymphoma. So one additional thing that I want to point out is that the EMBOLDEN trial exploring the value of pembrolizumab on our epigenetic backbones also accrue patients with cutaneous T-cell lymphomas, while the durability trial only accrue patients with peripheral T-cell lymphomas. So when we look at the preliminary results of the EMBOLDEN trial, we see that we enrolled at today 13 patients on trial. The demographic of the patients sort of mirrors the demographic of peripheral T-cell lymphoma in the Western country, with the majority of patients entering the study with an histology of peripheral T-cell lymphoma NOS, or angioimmunoblastic. Most of the patients had advanced stage disease, and the median number of prior therapy is 2, with a range of 1 to 5. And as in most of the literature, these patients are entering phase 1 study with significantly heavily pretreated disease. In terms of toxicity, grade 3 for toxicity that we recruited in this study, we had patients with thrombocytopenia, neutropenia, fatigue, vomiting, 1 patient with an immuno-related adverse event, hyponatremia, and rash. And looking at the DLTs in the study, we had a DLT for each arms, including respectively in arm A, B, and C of the EMBOLDEN trial. We had a grade 3 thrombocytopenia, febrile neutropenia, and an hyponatremia and rash. And when we consider the response of this phase 1 trial, of the 13 patients enrolled in the trial, 6 out of 13 patients are evaluable for response. We had 1 patient with complete response, 1 patient with a very prolonged partial response, 1 patient with stable disease. Interestingly, all the responders are in the triplet arm, arm B, and as I was mentioning, the partial response that we have on study, it's ongoing for 18 months. When we look instead at the preliminary results of the durability trial, in this trial, we are enrolling patients per arm. So most of the patients were enrolled now in arm A. And again, we have 5 patients that are enrolled on trial, with the demographic again mirroring the prevalence of the disease in the Western countries. Most of the patients entered the study with a diagnosis of peripheral T-cell lymphoma NOS, angioimmunoblastic, and T follicular helper phenotype. Again, we have patients with advanced stage disease. And in this case, again, the prior number of therapy is the median prior number of prior therapies is 2, with a range of 0 to 5, because as I was saying, patients can enter this study with the novel disease. In terms of toxicities, we had a grade 3 for toxicity represented by thrombocytopenia, lymphopenia, and we had 1 cytokine release syndrome. In terms of response, 3 out of 5 patients are today available for response, with actually 3 of these patients are available for response, demonstrating a complete response. So in conclusion, when even if this data are very preliminary, we can say that the addition of an immunocheckpoint inhibitors, either pembrolizumab or durvalumab on our epigenetic backbone, is safe and demonstrate encouraging response in patients with peripheral T-cell lymphoma and cutaneous T-cell lymphoma. And of note, we have not reported any hyperprogressive disease in patients that were treated with immunocheckpoint inhibitors on our epigenetic backbones.